another point about these trials, and obviously you would enroll people with bad liver function in a clinical trial. That makes no sense because you don't want to have a bunch of decompensations that
Right, they're
make your
excluded.
outcomes. Yes. So all of these trials looked at patients with preserved liver function. They were all Child-Pugh A, and there may have been one of them that did B7, but I believe they were all Child-Pugh A. Is that what we typically see in practice? Like, are you looking at an advanced patient like, yes, this is Child-Pugh A, they're going to get immunotherapy. It makes total sense. What do you see in practice? What's reality?
The reality is we don't have that many Child-Pugh A patients. The majority of patients, they're pretty beaten up. I would say maybe 1/3, definitely less than 1/3 is Child-Pugh A. We have a lot of Child-Pugh B, and we also have Child-Pugh C. That is not uncommon.
Yeah, I totally agree. It's a problem that we have that the trial population does not represent the real-world population of HCC that we see. We also see a similar breakdown here in Southern California of various degrees of liver dysfunction in our patients. And there are a few studies that are actually attempting to answer this question. So there are some ongoing studies for both the Tezobev, the Kiro study, as well as for durvalumab, the Sierra study, which are specifically trying to address this data gap of enrolling patients that have slightly more advanced liver dysfunction, the Child-Pugh B population, to see if at least this regimen is safe for us to give. We know from real-world data that's been presented in our own clinical practice that it is safe. We do it every day. But actually collecting that data in a more formal way to look at both safety and efficacy, I think, is going to be an important addition to the data.
Yeah, and I'll only add that we actually submitted for GI ASCO this year our data about what percentage of our patients are in each Child-Pugh category at the time of initiation of systemic therapy. And so it's not everyone we're seeing, it's just at the time the patients we're actually treating.
No,
so
they
it's
were
a little
actually
bit biased.
selected, like there's at least a candidate for systemic
Correct.
treatment.
And
right?
I think our like Child-Pugh A was in the 40 percentage. So obviously we're screening out some patients who
Right,
we
'cause
decided are
Child-Pugh
not
C,
candidates.
exactly.
Yeah.
When do you say that this is not a good patient for immunotherapy, right? Like, so obviously first line advanced HCC, they come through and you see this patient like, not really thinking immunotherapy here. Like, when do you say that? And then I guess, what is your next thought?
I think there's some very obvious thing that you can see is like, I'm not treating this patient. Of course, patients after transplant, any type of transplant, a lot of patients come to us after liver transplant. I would not give them immunotherapy. It's too risky. And then people with horrible autoimmune disease like bad lupus, like even bad Crohn's, and bad autoimmune hepatitis for sure, I don't think it's worth risking it. And then very poor performance status. I would say like ECOG performance status 3 or 4, like in a wheelchair, can hardly get out of a wheelchair. I'm like, forget about immunotherapy. Like it can potentially make you even sicker. And then poor liver function for sure. If you really go by the NCCN guideline, Child-Pugh C, the recommendations like palliative care and hospice, both on NCCN guideline and BCLC staging, right? When we first started having single agent PD-1, PD-L1 blockade, I treated a few patients with Child-Pugh C with like single agent PD-1, PD-L1 and did not work out well at all. Their liver just too poor.
So when you say bad liver function, are you looking at Child-Pugh status? Are you looking at bilirubin? Are you looking at albumin? Are you looking at it in combination? What does bad liver function mean to you?
It's also a very heterogeneous concept. For me, like Child-Pugh C for sure is bad liver function. And sometimes like I do find that my patient with hepatoencephalopathy, a lot of them, they cannot tolerate any treatment. Like when you start treating them, the encephalopathy really get worse. And even refractory ascites, I do find that it get even worse after systemic treatment.
I think of it in sort of two ways. I mean, these are monoclonal antibodies. They're not metabolized by the liver. So from like a safety perspective for other medicines, we don't have to consider that as heavily as we do for like chemotherapy, for example. However, if a patient is dying of their liver failure, it doesn't matter if I give them a complete response
Right.
with immunotherapy. If the cancer is not driving it and it's from their cirrhosis, I'm not helping that person. And the other question that I ask myself in thinking about immunotherapy and someone that's more frail is, if they had an immune-related toxicity, would I feel comfortable giving them high-dose steroids or other immune suppressive agents? And if I'm worried that that intervention would be potentially fatal or too risky for them, then I take some pause with thinking about offering that. But that being said, I have given immunotherapy to a cadre of patients in their 80s and 90s, including patients that have responded really well and done well. So this is something we never talked about in the TKI era. So it is something that comes with risk, but we are able to push the envelope a bit further just because the agents are relatively well tolerated.
Yeah, I'll add to that. I think that's an excellent point, everything you just said. And, I'll give an example of like, I've had patients where, you'd look at paper and you're like, oh, you're a B8, but,
Right.
but like their bilirubin's been 3.5 for like 3 years. And I'm like, maybe your liver disease is not going to kill you in the next 12 months. So like you are someone who I think like this liver cancer could kill you. And to me, that's like someone who, I would carve out and say, you are, to me, an appropriate person that we should try systemic therapy for, immunotherapy for.
So it's basically what you're saying is stable bad liver function, not a progressing bad liver function.
Correct. Like I explain to patients when they come in that we're, when you come in with HCC, we're fighting a war on two fronts. And one is the war against the cancer. We have some tools to treat that. And one is the war against the, or
Liver.
one front is against liver. And I ain't got tools to treat that, unfortunately. And if this is going to kill you before I ever have time to do any work, exactly what Aaron was saying is this is a futile exercise. So, hopefully we're catching the patients and treating the patients who are actually going to make a difference in their survival.
I actually feel that's very controversial. So, like, by theory, you should only treat patients with good liver function, right? But like you said, like these patients, they come in to see us, bilirubin 2 and 3, we give them the treatment. A lot of times what I tell patients, like, if you're willing to put up the risk, I can give you a dose. Like, we can just play by ears and see how you turn out. I definitely had patients like who were able to continue with treatment. It did not, like, their liver function did not decompensate too much after that. But I also had patients like the liver function decompensate after that.